Good afternoon, everyone. Thank you so much, Dr. Alvaro. We welcome you also in the Philippines, but to warn you about the jet lag, especially coming from East Coast. So I'm going to prepare some cases so that we can further elaborate the discussion on cardiovascular disease and psoriasis. So the first case, so we have this patient, 6-year-old female, who is multimorbid. So we have here obesity, diabetes, hypertensive, uncontrolled, and also had previous surgeries. So coronary artery bypass grafting was done. Patient has psoriasis for 5 years, severe scalp involvement, PASI of 12, BSA of 10, and very large affectation in terms of DLQI. So patient was treated with topicals, phototherapy, and also methotrexate. However, patient was not unable to comply because, of course, with phototherapy, you need to travel frequently to hospitals, and COVID also happened during these times. And of course, methotrexate will be difficult, especially with the drug-drug interactions with a lot of her medications. So patient was started with interleukin-23 inhibitor, started really well. Here you can see very good, remarkable improvement with the PASI. Similar also with the severity in terms of the scalp. You can see here at the baseline, very severe in terms of the scalp involvement. Very good improvement also afterwards. Another case who are also obese individual, we have here with a BMI of 49. We have here psoriasis for 8 years, psoriatic arthritis for 2 years. Patient has been treated with a lot of treatment options also like your topical steroids, methotrexate, and phototherapy. Unfortunately, this patient also had abused the topical steroids, especially in the Philippines. You can just buy steroids out of without any prescription and also anywhere easily available. And that, I think, is a big, major problem, especially for patients who have psoriasis. Patient has very severe psoriasis and also psoriatic arthritis, particularly on the left knee. If you can see here, it's going to be obvious in terms of the striae because of the topical steroids that the patient did abuse. Your patient was also started with your interleukin-23 inhibitor and really good response after the week 28. So very importantly, in terms of discussing cardiovascular disease, it's not only one aspect of comorbidity. I think it's a combination of comorbidities that entails also a big discussion among this group. So as a dermpath, you can see here the pathology of plaque and psoriasis. I don't think you need to be a dermpath to diagnose psoriasis in histology, but you can appreciate also another type of plaque that's in cardiology. So I hope that everyone here can also discuss the consequences of plaques among your patients, particularly those with calcified plaques or non-calcified plaques among your patients. It is indeed a systemic disease, so you can see here the involvement of chronic inflammation, not only in the skin, but it is more than skin deep. You have a lot of pro-inflammatory and chemotactic transcripts found in your patients with psoriasis versus that of a control. We have the power to screen and treat our patients. If you can see here, all these comorbidities, including your hypertension, is obviously seen among our patients with psoriasis. These are unrecognized and undertreated most of the time. If you can see here, the treatment is actually not ideal whenever seen in our clinics. So in your clinic, do you actually ask for your patient's blood pressure? Sometimes we miss it because we're too busy. It's just in your paper, and sometimes we have this missing out. A very good impact study here involved that a lot of our patients also can be detected their comorbidities such as your cholesterol, hypercholesterolemia patients, hypertension, and any other risk factors for all these comorbidities. So we need to ask and screen. So we did a study also in the Philippines with Professor Chris and also Darren, wherein we can see a lot of comorbidities, including your diabetes, mental health, and cardiovascular diseases, which is our topic also here. And these comorbidities did add further the burden with their current psoriasis among 79% of our patients. Very good also in terms of screening our patients in terms of their cardiovascular risk. Indeed, we have here a multiplier of 1.5, especially if your patient is severe with a BSA of 10% and also those who are candidates for systemics and phototherapy. A 10-year risk of coronary artery event or stroke is 6.2%. Very important also in terms of significant biomarkers, but I think Dr. Alvaro really summarized the importance of BMI being the best biomarker for cardiovascular risk. Treatment modifiable CV risk factors, indeed, of course, is importance of your optimal lifestyle modification, hypocaloric diet. I love the Mediterranean diet, but obviously in the Philippines, I think this is not really practical as of the moment, especially because of the cost of the real deal VCO or your oils. So in terms of this is that we have here the threefold higher skin clearance, especially if you treat your patients holistically, whenever you treat them with their psoriasis and also their comorbidities. So I guess just to summarize, wrap up in terms of top 5 key points with cardiovascular disease and psoriasis, is that psoriasis is an independent risk factor for MI or myocardial infarct. Your patients, compared to your general population, will have at least 5.48 times more of having MI. Discussing this to your patients will, of course, have this fear. Probably fear will also equate to good compliance. So similarly also in terms of your patients with severe psoriasis, your risk of having a 3-vessel disease is highly possible, especially with your severe patients as well. So inducing the pro-inflammatory and hypercoagulability state in patients with psoriasis, especially with the add-on of tobacco use, alcohol, decreased physical activity, metabolic syndrome. I guess these are very important factors also that we need to discuss. And finally, hopefully, treatment of psoriasis successfully, whether it's going to be topical, methotrexate, oral systemics, phototherapy, and biologics, I think remotely including your skin inflammation can potentially decrease the cardiovascular risk of patients with psoriasis. And I guess it's up to us, dermatologists. That's why we're here in the IPC session in terms of preventing comorbidities. And we want to focus also the importance of inflammation, not only limited to the skin, but also systemically, such as within your vessels as well. So hopefully you keep your fire burning, managing your patients holistically, not only on the surface and the skin, but of course, your patient's heart as well. So thank you so much.